Robotic unilateral TAR for recurrent kidney transplant incisional hernia. Our patient is a 78-year-old female with multiple medical comorbidities who developed a transplant incisional hernia due to end-stage renal disease. Patient had a robotic IPOM performed, which immediately failed and was referred to my office. We put her through prehabilitation for weight loss and increased level of fitness, which she succeeded on after a few months after our initial consultation. CT scan of the abdomen pelvis revealed bowel containing multiple Swiss cheese defects along that iliac incision. An important consideration is when you have a hernia in the groin, which is the lower margin of the incision, you still have to dissect that while avoiding injury to the artery, vein, as ureter. So the operative plan would be to place her in left lateral decubitus position, 3 ports along the left rectus, do a Reeves on the right, extend that to a TAR so I can get enough dissection to create an extraperitoneal plane to allow for the placement of a mesh that goes from midline to psoas, as well as offer a component release to be able to close all these defects. This was the initial laparoscopic view. You can see that IPOM, which would really never ever work. I always say with these hernias, if IPOM is the only technique in your armamentarium to avoid doing these type of hernias, because you really need these. Repair really depends on adequate posterior overlap. Here is the morphology of the Swiss cheese defects, and it's consistent with the overlying incision. There's some adhesions that we took down. Fortunately, the adhesions weren't too bad. That's the position of the kidney graft. You can see there. So very difficult. You got to determine, are you going to leave the mesh there? Are you going to take the mesh off? The mesh that I could take out, I took out. But if I took out that mesh down there in the lower abdomen, I would no longer have posterior elements to be able to create an extraperitoneal plane successfully. So we incised the posterior sheath along the right rectus as according to our operative plan. Did retromuscular dissection to the EIT junction. Here you see neurovascular bundle, and from distal to proximal, that always points towards the head. Here you see the anatomy of the retromuscular dissection. Here you see the subepigastric fat pad. It's really important that that all goes up to the abdominal wall off of the posterior sheath. So now I'm doing preperitoneal dissection down towards the level of the space of Bogros and dissecting in essentially zone 1 of the myopectineal orifice. You can see I'm dissecting on top of the failed intraperitoneal mesh. If I took that mesh out, I would have no more posterior elements. Now we want to get into zone 2, space of Retzius dissection. There's Cooper's ligament. Fortunately, it wasn't too scarred out in this area. Nicky Salovitz was my 5th-year resident who was consult 2 surgeon at the time, doing well over 50% of this very difficult case. Patient had a very wide pelvis, and we're just trying to dissect the bladder out of space of Retzius. Here's we're encountering the distal margin of that incision, or the lower margin of that incision, trying to partially reduce the hernia sac, but largely abandoning the sac, trying to preserve as much posterior elements as possible for subsequent peritoneal closure and extraperitoneal coverage of the mesh. Here you can see the disrupted anatomy of the incision. You can see the transversus abdominis muscle. You can see the layer deep to that being the internal oblique, and behind that is the hernia defect, or one of the hernia defects. My overall strategy with really any extraperitoneal surgery is to be able to dissect a layer off the abdominal wall, not include muscle on the floor of my posterior elements, taking down peritoneum, transversalis fascia, whatever it would require to provide subsequent autologous coverage of the mesh, even if that coverage is provided by the previous intraperitoneal mesh, like shown here. So we sequentially address each hernia defect. We don't completely reduce the hernia sacs of any of these defects, but we plan out to try to leave our holes or defects in our flap as minimal as possible. I feel it's always important to have some context of where you are in space. So many times I'll look underneath the flap. I'll see the location of where I think the hernia graft is. I'll ensure that I'm not injuring bowel while dissecting the layer off of the abdominal wall. But you can see here, there's a lot of scar tissue from previous intervention, from the incision itself, from the previous intraperitoneal hernia repair. And you really have to just burn right through the scar. And again, you don't want to cause any adjacent thermal burn injury to visceral structures or critical vascular structures as well. So here you see the anatomy of the retromuscular space going into the preperitoneal space below arcuate line. See the right rectus, space of Bogros. And essentially this is where I would do bottoms up, but because that mesh is part of that posterior element layer, I knew that we would leave a fairly significant hole in this area. This is very difficult to do a TAR, and I think you need to know multiple ways to do a TAR, whether it's top down, Nowitzki, whether it's going right through the aponeurotic TA, encountering transversalis fascia or peritoneum. But one thing you never want to see is muscle on the floor of your dissection. And I caught this while Nikki was doing the dissection. She caught it as well, understanding that that was not normal. So we knew we needed to get underneath that muscle. That's the transversus abdominis. And the transversalis fascia was just super poor in this area. Normally it's a little bit thicker than that. But I knew I was going to get a big hole. So essentially what I'm doing is I'm cutting the aponeurotic portion of the TA medial to neurovascular bundle. But I knew with our TAR mobilization, the release of the posterior sheath, the dissection all the way to retroperitoneal fat and psoas, that I'll have a nice, large, redundant flap to be able to close all these defects. Knowing I wouldn't be able to save the posterior elements there doing a typical bottoms up, I just cut the lateral posterior sheath, which is the aponeurotic TA. But again, medial to neurovascular bundles. That would leave a pretty big hole there, and I understand that. And now I'm doing preperitoneal dissection of the hernia sac, reducing as much hernia sac as possible. I honestly just wanted to abandon the sac at this point, but Nikki was pretty successful in being able to preserve as much sac as possible, reducing that down and carrying that dissection to the retroperitoneal fat. You can see transitioning back into that retroperitoneal plane as opposed to pretransversalis plane, it's a little bit less bloody. So now we've dissected above and below the area of where we suspect the kidney graft to be, and that's typically what I'll do. Again, I'll leave the hardest part for last, and the thought is you want to be behind the kidney, lateral to it, and don't go medial where the hilar structures are. So long as I stay lateral and on top of the kidney, I feel like I can be safe and mobilize the kidney effectively. But I'm looking here now in the groin. This is zone 2, my pectineal orifice, and a little bit of thermal burn can disrupt the serosa of the bladder there. You don't want to leave that. I know that that's injured. Here I'm asking for a suture, and we just repair this with some Lambert sutures oversearing the area of the partial thickness injury to the bladder. So on further dissection, this would be towards zone 3 of my pectineal orifice. I'm looking at this structure, not realizing exactly what that is. I was thinking that can't be the round ligament, and I'm just looking and looking closer, and it's clearly going right into the bladder, and it looks like it's emerging right from the hilum of the kidney graft. So we conclude that that's ureter. We don't want to mess with that, but we need to dissect it a little bit to be able to get some element of overlap of that lower portion of that incisional defect. See the anatomy of the lower margin of the hernia and its relationship with the ureter, the kidney graft, and the bladder. So I'm pretty satisfied with my space of retius dissection. I'm still wondering if I need to mobilize that ureter a little bit more, and thinking in order to get enough overlap, do meticulous and judicious dissection, and was able to drop down that ureter into the space of retius. Now we turn our attention to medialization of the kidney, and again, you want to stay on top and lateral to it. We have table motion to be able to assist us get her into a more right-sided up position. And this honestly wasn't too bad, wasn't too scarred in. We saw some nice virginal type of fat on the lateral abdominal wall. Again, the trick is you want some kind of layer of your posterior elements, but no muscle down on the floor. You can see I was a little bit confused in how thick this was, this area. So this was some scar of the kidney graft, but I easily got through that. And you can see TA on the lateral abdominal wall. And if that's intact on the lateral abdominal wall, that means there can't be any muscle on the floor of your posterior elements. So now we're completing space of Bogros dissection here. This will give me enough overlap as well along the myopatinia orifice in zone 1. Now I'm just trying to see if I have enough overlap of all the defects. Certainly, you would love to dissect that more, but I'm not going to dissect the entire ureter off the lateral abdominal wall. Nor did I want to mess with the hilar vessels. And again, I do a lot of transplant incisional hernias, and I say the priority is obviously the vitality of the patient. Second priority is preservation of the kidney graft, and third priority is the hernia repair. But you can see here I'm seeing all the way down to quadratus, all the way down to lateral border of psoas. You can see the ilioinguinal nerve emerging from the underbelly of the quadratus lumborum muscle. Now I'm utilizing barb suture to be able to reconstitute the posterior layer to close all defects and rents in my peritoneal flap. You can utilize the head-in menu now to decrease pneumoperitoneum, as you see here. Now we are utilizing number 1 barb suture to bring the muscles back to where they should be. I could be suturing the TA and IO back to the EIT junction, or TA back to TA. Whatever it takes to put the muscles back to where they should be to allow for these muscles to be able to hopefully fire maximally, to be able to augment the quality of life and restore some element of core function. So as you see here, we have the right rectus abdominis muscle, the EIT junction reconstituted, transversus abdominis back to where it should be in its relationship with the iliacus. You can see the before and after effects, and again, I was pretty happy with this repair. If there's a hernia in the groin, I like to use 2 separate meshes. It's hard to fit a mesh in the lateral abdominal wall and curve it around to fit well in the pelvis. I want to stay away from obviously the hilar structures here. This is a 12 by 16 centimeter or 12 by 17 centimeter pro grip, polypropylene pro grip that I used. And this is a heavyweight Marlex, and I tend to use heavyweight in any significant off midline defects. We place cardinal sutures on the heavyweight mesh just to make it look flat. We utilize Tacil for hemostasis and hopefully a seroma control of this big pocket that's opened, and then we suture the posterior sheath back together with 2-0 barb suture. Patient did well. She was discharged on post-op day 2, returned to her home in New Mexico. This is the 2-week post-operative visit. A little bit swollen, but thriving. Thank you.